Hello everyone. Today we will discuss about isoflupredone toxicity and hypokalemia. We all know that isoflupredone is a corticosteroid. It's a synthetic corticosteroid, okay, and it has equal glucocorticoid and mineralocorticoid effect, and they are 25 times more than that of cortisol. Cortisol is a natural corticosteroid. Dexamethasone, prednisone, and isoflupredone they are synthetic corticosteroids. Cortisol Cortisol has been assigned a value of 1 for mineralocorticoid and the glucocorticoid effect as a reference value, and its effect is for 8 hours. This short-acting corticosteroid. Dexamethasone has 25 glucocorticoid action and 0 mineralocorticoid action, and effect is for 72 hours, that is long-acting. Isoflupredone has 1 glucocorticoid, 0.8 mineralocorticoid action, and action is for 24 hours, that is intermediate acting. Isoflurane is long acting, okay, but it has 25 times glucocorticoid effect and 25 times mineralocorticoid effect. Okay, now here we will learn what is the mechanism of action of isoflurane toxicity. Isoflurane has glucocorticoid effect, okay, it causes increase in glucose concentration, it causes gluconeogenesis, it causes increased glucose metabolism, but toxicity is not because of glucocorticoid effect, okay. Toxicity of isoflupredone is because of mineralocorticoid effect. Okay, it has 25 times mineralocorticoid activity than that of cortisol. So there is 25 times more loss of potassium than cortisol. So when there is loss of potassium and hydrogen and reduction of sodium, this action is it is mineralocorticoid action. This is mineralocorticoid action. So when there is loss of potassium, there is hypokalemia. And how hypokalemia causes this toxicity, and hypokalemia is clinically manifested. What it causes muscle weakness. How? It causes lowering of resting membrane potential of neuromuscular tissue. When there is lowering of RMP, what happens? There is decreased excitability of the muscular tissue, and which results in the muscle weakness. So when there is any case of muscle weakness, hypokalemia must be kept in the differential diagnosis in that case. Now here you can see mineralocorticoid effect. It is because of potassium excretion, okay, and there is sodium absorption. So sodium absorption and potassium excretion is mineralocorticoid effect, and it is because of this effect potassium is lost. It causes hypokalemia, okay, it causes hypokalemia, and it causes muscle weakness, okay. As we all know, we use isoflupredone in the ketosis, but do you know how it is used and what is the dosage? In this slide we will discuss. First we will know about hypokalemia. Hypokalemia is when potassium concentration is less than 3.9 milligrams per liter in serum or plasma, okay. If we use the higher doses of isoflupredone acetate, it can result in the profound hypokalemia, and which has also high case fatality rate, okay. So that is why only one treatment of isoflupredone acetate is recommended for the ketosis, and the dose is 10 to 20 mg IM only, okay. Even single dose of isoflupredone acetate causes 25% loss of potassium from the body, okay. Other conditions where hypokalemia occurs. First is all the conditions of abomasum like LDA, RDA, abomasal volvulus, abomasal infection. They cause retention of potassium, and there is decreased potassium absorption, and which results in the hypokalemia. Also in clinical mastitis, dystocia, ROP, and hepatic lipidosis. Alkalosis also cause hypokalemia because there is exchange of potassium ions for hydrogen ions in the renal system, which results in hypokalemia. As we know, hypokalemia is seen in sick lactating dairy animals. It is because of combination of decreased dry matter intake, okay. There's alkalemia because of LDA RDA AV or decreased abomasal emptying rate, due to which there is potassium sequestration in the abomasum and rumen, and it is not absorbed. Hyperinsulinemia secondary to the hyperglycemia. When there's hyperglycemia, when there's more glucose in the blood, it results in the increase in more insulin secretion, okay. When insulin is secreted more, it causes potassium to go inside the cells, which results in the hypokalemia, okay. Also there's obligatory loss of potassium in the milk. 1.4 gram of potassium is lost per liter of milk, okay. Aldosterone release in response to hypovolemia. When there's hypovolemia, aldosterone is released, okay, When aldosterone is released, it causes the potassium loss. Okay. So here we will discuss about the etiology and pathogenesis of hypokalemia. Okay. Number one, abomasal stasis like LDA, RDA, AV impaction. There is sequestration of potassium in the abomasum, which results in hypokalemia. Also, repeated administration of corticosteroids like isoflupredone, they cause loss of potassium and results in hypokalemia. Intestinal obstruction, enteritis, they also cause loss of potassium from the body. And in intestinal obstruction, there's absorption of potassium is hampered, due to which there's hypokalemia. Also, if we treat acidosis, there's also hypokalemia. Decreased dietary intake also leads to hypokalemia. And in alkalosis, there is loss of potassium compensated to the hydrogen ions, which causes the hypokalemia. And when hypokalemia occurs, what happens? These are the clinical signs: muscle weakness, recumbency, depression, muscle tremor, arrhythmia, and finally coma. Now, what is the treatment for the hypokalemia? It is oral potassium chloride 120 gram हमें देना है per hour 2 times a day. Okay, and we have to increase the feed intake, and we have to give supportive care like tonics. The contraindications in this treatment protocol are: dextrose is contraindicated because when we give dextrose, there's a release of insulin, which causes potassium to go inside the cells, which results in hypokalemia, and it exacerbates the hypokalemia. Also, we should not use Mifex and calcium preparations containing dextrose. Like we know, Mifex and other preparations of calcium contain 20% glucose, and if we give them, so there's enough insulin and potassium will go inside the cells, and it will exacerbate the hypokalemia, and animal will not get recovered. Don't use soda bicarb solutions as they cause hypokalemia. We know that soda bicarb is causes alkalosis, or it is alkalizing agent. Okay, and alkalosis causes loss of potassium in the spite and retention of hydrogen inside the body. Okay, so potassium is lost and hydrogen is retained, which causes hypokalemia. So soda bicarb is also contraindicated in case of hypokalemia or isoflupredone toxicity.
Regarding NS and oral, NS can be used easily because NS is acidifying, which will cause movement of potassium from cells to plasma. But oral cannot be used because oral is alkalizing and it will cause loss of potassium through urine. This was all about isoflupredone toxicity or hypokalemia. If you have any query or any confusion, you can comment below. Thank you so much. Take care. Bye bye.